Is Dr. Ramanuj Samanta. He will speak on management of post-traumatic retained intraocular foreign bodies, case-based practical approach. Please note that time is 7 minutes and you will get the bell after 6 minutes.
Thank you AIOCMT for the opportunity. So we have shown some nice elegant videos by Dr. Ashok sir for removing the corneal foreign bodies. So what about the posterior segment foreign bodies? So IOFB may be multiple in number in up to 25% of cases, and the commonest location is posterior segment. The most commonly it's metallic, and most commonly they enter through the cornea. The commonest mode of injury is through hammering. So when we suspect posterior segment intraocular foreign bodies, if we see some focal lens opacities, iris transillumination defects, iris heterochromia, or small self-sealing wounds, we would suspect that there is possibly some intraocular foreign bodies. So there are various imaging modalities. Plain X-ray is a good screening tool. CT scan has high sensitivity, can detect multiple IOFB. MRI has a good, better visualization, but is avoided in magnetic IOFBs. USG helps in surgical planning especially. UBM and ASOCT is especially for anterior segment or sulcus foreign bodies. So you can see X-ray can pick up, is an easy screening tool, but sometimes X-ray can miss some foreign bodies that the CT scan might help. USG provides additional information about the posterior segment. You can see there is post-acoustic shadow, there is presence of incomplete PVD and vitreous hemorrhage, and also helps to rule out retinal detachment. So the timing of IOFB can be early or late. Early IOFB removal from posterior segment, the wound visibility is more difficult. Posterior hyaloid removal is more difficult. There is more risk of intraoperative hemorrhage, but the risk of endophthalmitis, metallosis, retinal detachment, and lawsuits are less. So there are two routes, mainly transcorneal and transscleral, I will show in the videos. So let us come to some videos. One of the first case was the foreign body lodged in pars plana region. So after we can see that injecting triamcinolone acetonide posterior vitreous was, PVD was injured, thorough vitrectomy was done. So in this patient, the foreign body was lodged in the pars plana and there was vitreous incarceration. So you can see the foreign body. So we removed it after vitrectomy through an external cut down with an MBR incision, and we can remove the foreign body through the external route with a simple McPherson's forceps. So coming to the second case is an encapsulated IOFB impacted at retina with siderosis. So in this patient, so we can see there is presence of foreign body in the inferonasal retina with some siderotic changes. So here it is important to remove the hyaloid and free the foreign body from the surrounding retina and remove the encapsulations around the foreign body, gently tease out the foreign body. You can use some PFCL in the posterior pole so as to not to hurt the macular region. Then after gently dissecting out, sometimes if it is late presentation, it can get encapsulated. It's lifted with the magnet, and we have already done lensectomy, preserved the anterior capsular rim, and with a bimanual handshake technique with intraocular forceps, we have exteriorized with a limbal wound. And here the anterior capsular support is present, and you can always implant an IOL in the same settings as in this case for visual rehabilitation. Third patient is an IOFB impacted at macula with VH, subretinal bleed, and clear lens. So in this patient, there was the foreign body was just juxtafoveal region, and there was presence of subretinal bleed, VH. We just teased out the foreign body gently, taking care not to damage the fovea. And after we have freed the foreign body, we gave an incision external, again tried to save the lens. But when we tried to took out with an intraocular forceps, it got entangled in the pars plana region. So we gave another small incision, took the magnet, and just lifted the foreign body into the mid-vitreous cavity with the help of magnet and took it out with the forceps by bimanual technique handshake. The lens was well preserved. There was no need of lensectomy and gentle laser, and the patient achieved good vision. The fourth patient was IOFB at retina. There was also retinal detachment, and the patient had traumatic cataract. So here the foreign body was large. We did lensectomy. Then we went ahead with the complete vitrectomy, ensuring the complete removal of the posterior hyaloid. You can see the foreign body is in the inferior mid-peripheral retina. Triamcinolone acetonide was injected. Posterior hyaloid was removed, and you can see some star folds. PFCL was injected to flatten the retina. Lensectomy was completed, and then again we preserved the anterior capsular rim, teased out the foreign body from the retina, and once you have freed the foreign body, you can lift it with either with the magnet or with the intraocular forceps, and when it was in the over the intracapsular rim, then you can take it out with again a bimanual technique with the help of a forceps. Now there was a star fold, so we need to do a relaxing retinotomy to prevent free retinal detachment. So once the relaxing retinectomy was done, the retina was free. Now we can put oil tamponade and the retina was attached. Last patient is an IOFB at ciliary sulcus. So this was an interesting patient referred from elsewhere. There was a focal iris defect, and the patient underwent an X-ray. No foreign body was seen outside, but we had a high index of suspicion, so we did CT. Foreign body was seen. So when we did gonioscopy, we could see the foreign body lodged in inferior ciliary sulcus. So what we did for removal is, in this patient we did and gave an incision with an MBR for an AC maintainer. Once we have introduced the AC maintainer, we tried to take it out through the iris hole directly with the magnet, but we could not get hold of the foreign body with the magnet. So what we did, we introduced two more ports and introduced iris hooks and expanded the area. Now with the help of a muscle hook, we depressed, and with the help of a foreign body posterior segment forceps, we took it out the forceps and exteriorized the foreign body through the limbal wound. So we also published this case in BMJ. So these are the complications. So in conclusion, high index of suspicion is required to diagnose intraocular foreign body. Appropriate imaging, mostly USG plus X-ray and/or NCCT orbit is sufficient. Appropriate instruments should be made available according to the nature of IOFB prior to the surgery, and management should be customized according to the cases. So this was the last case I operated this week only. This was a foreign body which was a nail completely impacted through the cornea into the retina. You can see in the CT scan going from right into the anterior to the posterior cords, and when I removed it, it's more than 3 centimeters. So you need to have proper instrumentation and proper planning before the surgery. Thank you for your patient hearing.
Thank you, Dr.